Well, hello and welcome. This is another in our series of resident basics, and we're talking today about a very common area in gynecologic pathology, the common epithelial and stromal tumors, and specifically we're going to be limited to the serous and mucinous tumors. Our focus is to help you figure out those things you need to know to take care of patients, and of course to pass your boards and qualify to practice. So our objectives are to cover some of the critical decision points in classification and nomenclature, as well as staging, and with regard to two of the most common types of ovarian tumors. It's important to realize that there are some areas of debate and controversy in this area, and therefore looking for opportunities to improve your practice and to see how that can impact better care and for the patients. As we think about this topic in general, there are certain things that we think about relative to classification. First, of course, is the epithelial cell type or cell of origin. We look at the amount of stroma that's present and then where it's located. Obviously, today we're focusing on the ovary. But there are a number of suffixes and prefixes, such as fibroma or cyst and so forth, that can come into play in terms of annotations and so forth. And then in terms of grading, there are a number of systems out there. The FIGO gradings, perhaps the most widely used. WHO has a grading system. GOG, these are fairly similar. And then for some tumors, there's the more Silverberg or Nottingham-like grading system, which I don't have a lot of experience with, and so I'm not going to comment on in any detail, but just to be aware that there are other grading systems in use. So first of all, it's important as we think about ovarian cancers to realize that this is a common disease. I think we see serous carcinoma every week, maybe sometimes several times a week in our practice. And so it's something that we have to deal with regularly. It's also important to realize that ovarian cancer can present very nonspecifically with vague symptoms. And it's also important to realize that hormonal issues can present themselves as part of the process. We also have circumstances where paraneoplastic syndromes may be the first manifestation of disease. Obviously, we're looking for biologic markers, ways of detecting this tumor at an early stage. Now, relative to staging, this is the HGSC clinical staging, also the FIGO staging, and it devolves around a couple of key questions. Is the tumor confined to the ovaries, and therefore stage 1? Does it have pelvic extension? In other words, is there involvement of more than one ovary and other areas or other tissues in the pelvis? And then is there either microscopic or macroscopic tumor beyond the pelvis? So that's a fairly simple parameter. But within this, there are some additional sub-questions, such as, is there surface involvement? Is the capsule of the ovary intact? Is the acidic fluid positive on cytologic exam? And what are the sizes and extent of the extrapelvic disease? So those are all clinical things that oftentimes the pathologist can answer at the time of gross evaluation. So you need to know the staging at the time when you first approach the specimen to make sure that you can answer these questions. Is the capsule intact? Is the surface involved by tumor? What's the volume or size of extraovarian disease? Is it limited to the pelvis? Is the fallopian tube involved? Could they be the source of primary tumor? And so forth. So those are questions that need to be considered at the initial time we first encounter with the specimen. So let's begin here with the serous tumors, which are certainly the most frequent lesions that we encounter, and can be a lot of fun. Of course, the benign lesions are common. About 60% of total serous lesions are benign, and they cover a wide age range. really. And in terms of behavior, the amount of stroma, the amount of cystic change doesn't make a whit of difference. Cystadenoma, adenofibroma, cystadenofibromas, these are all the same disease, the same outcome, and so forth. Now, there are questions because certainly there's a spectrum here. And so how much does it take to call it a tumor? Is it just papillary surface excrescences? When does it really become an oma? And you, in your particular practice setting, may have various parameters. Some people use size parameters, some people use extent. But essentially, I think the determination, if it's clinically evident, grossly evident, it's usually going to be an oma kind of lesion. And of course, other things can give you cystic lesions, papillary structures, and so forth, and those enter into the differential diagnosis. Here's a fairly typical appearance of a mixed cystic solid lesion with very thin walls to the cysts. You can see the vascular pattern, glistening surfaces without any complexity, without any fleshy areas per se in the gross tissue. Sometimes the tumor is limited to the surface. And so here's an example of surface papillary cystadenofibromas involving both ovaries, as you can see in this image. And under the microscope, these are very bland, not very exciting. Although the areas can be variably edematous or fibrotic. And again, the papillae can look a bit like puzzle pieces fitting together, maybe where 4-year-olds kind of force them together in a few areas in that way. The stroma can be variably spindled or fibrotic, but the epithelium is not very complex. There's no stratification and certainly no significant atypia. So the next stage up is the borderline category, the atypical serous tumor or serous borderline tumors, which account for a significant percentage of serous tumors and typically are problematic because they present in a reproductive age group. They're often stage 1 or 2, and stage 2, meaning bilateral in a fair number of cases with surface involvement. It's important in these lesions to sample them thoroughly, to take plenty of sections, 1 to 2 blocks of tumor per centimeter, or 1 to 2 blocks per centimeter of tumor, and then even the grossly negative omentum should be sampled. So the question sometimes arises, well, how much does it take to call it a borderline tumor? If I have 1 microscopic field, is that enough? Well, generally, behavior is going to correspond with the amount of epithelial proliferation that's present. And so certainly a very, very confined, very microscopic change within a confined area may not bode anything ill for the patient. But on the other hand, a small area of borderline change in a surface location may be the harbinger of potentially more serious persistent disease. Immunohistochemistry is rarely required, but these do tend to have epithelial markers, be positive with hormone receptors, WIT1, as well as to be non-mutated with p53 if you're concerned about differentiating it from high-grade lesions. Here's a nice gross example. We can see here some surface involvement, very papillary structures on the surface of this cystic lesion, as well as papillary spongy yellowish white tissue in the center of the cyst. Under the microscope, these lesions look busy. They look very concerning. The cells tend to pile up. There's a little bit of redundancy and a little bit of stratification, and we get this hierarchical branching. So here's the core, here's a main papillary structure, and then we get little tufts off to the side, sometimes with and sometimes without any recognizable stroma. Here's another example showing this very uniform tufting and pattern forming stars and staghorn complexes within these dilated spaces with fairly uniform invagination. The stroma is fibrotic, and so this is one image that you can cement in your mind for what a borderline tumor can look like. But they can be quite variable. And so here's another example of one which is producing quite a bit of mucin. So serous tumors do not necessarily have to have cilia. They can produce mucin and still be a predominantly serous phenotype because they don't have abundant mucinous cytoplasm and so forth. Now there's one special pattern that merits particular attention, and that's the micropapillary pattern. These are about 10% of the serous borderline tumors based on the criteria of greater than 5 millimeters of pattern. The challenge here, of course, is that some observers have found that with even as little as 1 millimeter of this micropapillary morphology, the behavior can impact or can be impacted. And the cribriform pattern is also included in this micropapillary variant. These tend to be bilateral more frequently, to have microinvasion or extraovarian implants or even positive lymph nodes. And for that reason, many observers, particularly those of the Kerman group, will tend to classify these as low-grade serous carcinomas. And I believe the most recent WHO classification includes them in that category as well. So here's a nice example side by side of conventional serous borderline tumor on the left and the micropapillary pattern here on the right. This is the characteristic Medusa head pattern with these streaming papillae and a very acellular fibrous core forming the head, and this is the hair mimicking the ancient caput medusa of Greek mythology, with the snakes captured by on the head of the Medusa that was slain by Perseus. Here's some more examples of this appearance, and here we see, several of these, paucicellular cores surrounded by this filigree proliferation of cells in this micropapillary pattern. One of the definitions has the micropapillary pattern being 5 times as long as it is wide, and so that's also a criteria that's been used. And there can be certainly some nuclear atypia associated with this, though it does not come close to the atypia of the high-grade serous carcinomas. Here's the cribriform variant of this micropapillary carcinoma. You see the very punched out rounded spaces with a little bit of intracellular or intraluminal mucin, and this also should be classified as the micropapillary variant. Some of the things that we can see with this are areas of microinvasion. So here's not a micropapillary version, but here is a papillary area with clear-cut invasion and extension into the stromal stalk. Here's rounded areas, and here we see both single cells at high magnification as well as small papillary clusters. Now this can be a little bit challenging sometimes because of retraction. Is this just an invagination or that sort of thing? But careful scrutiny, and especially if you find single cells like this, that's a good marker. Immunohistochemistry may be useful in sort of highlighting this drifting off of the cystic structures and the single cell pattern within the stroma. This is just a cytokeratin immunohistochemical stain. Here's an example of some of the nuclear atypia, and you can see where this might begin to make you wonder about a clear cell carcinoma, because there is a little bit of sort of higher grade atypia and almost a little bit of hobnail type configuration in these cells with abundant cytoplasm. So let's talk about one of the vexing problems with serous borderline tumors, and that's the implants. As you know, these tumors can spread within the intra-abdominal cavity and the pelvic perineum, and that does not necessarily imply malignancy. And so we have things that have come up with regard to definitions. One is what's been termed non-invasive implants, which is the vast majority of them. And these are cells, stroma, and xanthoma bodies that are confined to the surface of the peritoneum. They generally look like the primary tumor. They're sharply circumscribed and fairly easily retained, and have some sort of mesothelial component. In contrast, invasive implants then tend to be more haphazard, more frequently have the micropapillary pattern, have more frequent desmoplasia, and usually do not have surrounding mesothelial calretinin positive cells. However, they can coexist with non-invasive implants, and the desmoplasia is not definitional for invasive implants. So here's one example of a non-invasive implant within the fallopian tube. We see these intraluminal cells with papillary patterns, ammoma bodies, and so forth, in contrast to the normal tube epithelium around them. Here's what's termed an autoimplant, where a serous borderline tumor, as seen up above, has evoked a somewhat desmoplastic response within the wall of the cyst. And you see this sort of desmoplasia with scattered cells scattered in it, areas of hemorrhage, but a fairly sharp margin with the underlying tissue, as though it could just be stuck on or peeled off. As we look at higher magnification at this implant, we can see, here's this desmoplastic tissue surrounding it with lots of granulation tissue type vessels and streaming myofibroblasts with these nests of tumor present. Here's another example of a non-invasive implant. Here in the omentum, you see no response. It's just tumor cells sort of floating in the interstices between the fatty lobules, areas of ammoma body change here, and no reaction. Here's a desmoplastic implant, but one that you would classify as non-invasive. And so the reason we can do that is you see it has this very sharp border, as though it was just sort of stuck right on the fatty tissue. And though even though we have this desmoplastic stroma and some inflammation up here, this is not merit the diagnosis of an invasive implant. Another example, desmoplasia around, but doesn't necessarily imply an invasive type of implant. In contrast, here is an invasive implant with this micropapillary lesion. Now, this is a higher magnification view, and so it's difficult to see how it relates to the surrounding tissue to qualify it as truly invasive. But the haphazard pattern, the cribriform pattern, and these micropapillary structures should lead you to look very carefully. Here's maybe the more low power appearance in an omental sample, where we can see that there's just more abundant tumor that's clearly evoking a broad-based area of desmoplasia. We have tumor abutting large vessels. We also have a lymphoid inflammatory response here. And these markers, particularly the vascular anatomy there, should clue us in to term this as an invasive implant. Now, I'll quickly say that I'm not an expert on implants, and that if you want to research this further, Google Dr. Aeneas Malpica from MD Anderson, who's given some great presentations on this topic that are available on the web as well. So what do we do about lymph nodes in borderline tumors? Well, the truth is that a fair number of borderline tumors have lymph node metastases, or at least have lymph node implants. Most commonly in the pelvic, but can be seen in mesenteric, peri-aortic, and even subdiaphragmatic nodes. In this situation, yes, you can try to differentiate it from just nodal endosalpingiosis, which would be a more benign Mullerian implant without any atypia. This may be quite difficult. But fortunately, lymph node status does not really seem to correlate with outcome when we take stage into account. So lymph node status does not particularly change stage grouping. And here's some examples of what we can see in lymph nodes. Here's a more micropapillary pattern here in this lymph node. Here we see just floating tumor cells within a subcapsular sinus. And then on the right, we see this more desmoplastic response in a lymph node. And so this might be more commonly interpreted as serous carcinoma, low grade, metastatic to a lymph node. And I think once you begin to develop mass displacing or invasive metastases or implants in a node, that's probably the better terminology to use. Here's a contrast showing you the side-by-side appearance of endosalpingiosis here on the left, with the focus of serous borderline tumor here on the right. Whether this is father and son, mother and daughter, or independent occurrences is difficult to ascertain at this point. Well, so how do these patients do? Generally, it depends a great deal on stage and extent and skill of the gynecologic oncologist or gynecologist taking care of the patient, because staging and any residual disease that's left behind are important prognostic factors. The presence of microinvasive tumor or micropapillary pattern obviously bodes a poorer prognosis. And so this is why we need to sample thoroughly and to make sure that we're not missing some of these type of features that may provide a better guide for counseling the patient and developing optimal treatment. So let's move on to the clearly serous carcinomas, which can be such a common event in a busy gynecologic oncology center. High-grade serous carcinoma, as I indicated, is something we see virtually every week. And most of these are generally thought now to arrive from serous-type epithelial neoplasia or from potentially tubal implants on the ovary. High-grade ovarian cancer, high-stage ovarian cancer is almost without exception going to be high-grade serous carcinoma. To find high-grade clear cell or high-stage clear cell or high-stage endometrioid is not impossible, but 9 out of 10 cases are going to be serous. And there are various microscopic patterns which can be challenging to the differential considerations if you don't see these with some frequency. Here's a typical gross tumor with fleshy, solid cystic areas, areas of hemorrhage and necrosis. You see the surface here having this very congested, complex vascular pattern. And here, a surface version of serous carcinoma. So it's important to recognize that surface serous carcinomas also can arise without obvious parenchymal invasion or origin. So here's the one microscopic pattern of the slit-like spaces with high-grade nuclei, micropapillary features, as we see here. Here's another pattern, a more papillary pattern, similar to what we might more commonly associate with low-grade serous carcinoma. But increasingly, we're beginning to define these by virtue of mutation status with P53. And so a tumor like this that maybe looks a little bit low-grade, if it has a either high-grade nuclei or a P53 mutation, would be best classified and treated as a high-grade serous carcinoma. Here's more of the different tumor types, patterns. We can have a cribriform pattern with this. Here's a solid and microcystic pattern, higher magnification here with these almost pseudoglandular mucinous type spaces that can be seen as well. Just to give you an idea of the spectrum of morphology. And if you look hard, you might even see a few hyaline droplets here. And this would not necessarily dissuade one from calling it serous or confusing it with clear cell carcinoma. Here's another pattern with desmoplasia type of reaction, similar to what we saw there with the low-grade serous borderline tumors, but can also be seen in frank serous carcinomas. Here's again this very micropapillary floating tufts of cells. And this is why in serous fluids, pelvic washings and so forth, finding these tufts is not usually terribly difficult. There can be high degrees of pleomorphism in some of these tumors, prominent nucleoli, very macro nucleoli, and macro nuclei as well. Immunohistochemistry is very helpful in differentiating both low and high-grade serous carcinomas. So high-grade serous carcinomas, we typically use a panel that includes WIT1, PAX8, P16, and P53. And we may also include estrogen progesterone receptor. For low-grade tumors, we would include WIT1, PAX8, P53, and P16, again, to look for the differentiation, because P53 will not usually be mutated in low-grade serous tumors, whereas the high grades are. And P16 expression will be strong and diffuse in high-grade serous carcinoma, whereas only focally present in low-grade tumors. This corresponds to other levels of mutational differences. High-grade serous carcinomas are more commonly associated with BRCA1 and 2 mutations, whereas that's very uncommon with low-grade serous tumors, where you tend more likely to have BRAF or KRAS, beta-catenin type of mutations present. So when we see a high-grade carcinoma that's presenting as it were in the typical fashion for serous carcinoma, what should we be concerned about? Well, endometrioid carcinoma rarely comes into the differential, especially if you've got negative WIT1 or a wild type P53 staining pattern. Clear cell carcinomas or clear cell areas can be seen in some high-grade serous carcinomas, and so looking for the morphology features of serous carcinoma, clear cell carcinoma, as well as the absence of ERPR, WIT1, and no P53 mutation, that might steer you more towards clear cell carcinoma. These other tumors are much less frequent and much less frequently enter into the differential diagnosis, save perhaps for undifferentiated carcinomas, which would have a mixture of features and would not have the characteristic findings of serous carcinoma in terms of P53, WIT1, and P16. They may have one or more, one of those, but not all in the typical fashion. So here's some examples of a high-grade serous carcinoma with some clear cell-like areas, as we see here, and another with more eosinophilic granular cytoplasm that might be mistaken for squamous carcinoma or endometrioid carcinomas, for example. Now, since these patients may not infrequently present at high stage and get neoadjuvant treatment before they come to definitive surgery, it's important to recognize that chemotherapy can impact these tumors and their morphology. So here's an example of serous carcinoma with some chemotherapy-related changes, producing some multinucleate cells, some nuclear smudging, maybe some mitotic arrest cells, and a lot of surrounding histiocytes and lymphoid reaction. The changes can be quite striking at times, and the histiocytic reaction can be almost overwhelming, leaving nothing in terms of recognizable tumor behind. With low-grade serous carcinoma, these are less frequently encountered. They do tend to be younger patients, but they may be high stage. And this is a situation where often there's a background of serous adenofibroma or borderline tumor, and occasionally we'll see lots of psammoma bodies with relatively low mitotic counts. Not infrequently, but not terribly commonly either, we can see associated high-grade serous carcinoma associated with low-grade versions. Here's an example of a higher stage tumor that's invaded through the muscularis of the colon. You see the typical papillary structures, and here it's bulging up into the muscularis, into the submucosa of this tumor. Higher magnification, we can see these tumor cells with really tufted nuclei, almost hobnail type cells, abundant psammoma bodies, and these confluent papillary structures. Here's a mixture of both borderline or benign serous tumor with a more confluent micropapillary serous carcinoma. Just to look at these nuclei, I think for a second or two, you can see that they tend to be fairly uniform. We may have small psammoma bodies. Nuclei are not usually macronuclei. They're present and prominent, but not overpowering. And if we do the WT1 stain, here we see just a few cells positive, indicating that it's still the wild type expression. Psammoma carcinoma can be one of the presentations of low-grade serous carcinoma. As we see here, very dominant presence of psammoma bodies with this lamellated calcification, and only very rarely identifiable areas of epithelium. In terms of behavior, low-grade serous carcinoma, unfortunately, is not totally benign. These tumors do not grow quickly, but they're not also very chemo-responsive. And so although they do very well at 5 years, by 10 years, complications and progression can lead to almost similar outcomes to high-grade serous carcinoma, which is very chemo-responsive. And this is especially true if during the course of disease they evolve into a higher grade serous tumor. We know that these are two different molecular pathways, and so those crossover types are not terribly frequent. So with that, let's leave the serous category behind and go on to look at what happens with mucin. Mucinous neoplasms in the ovary, again, quite frequent, and some vexing challenges with these tumors. These are, 10 to 20% of ovarian neoplasms, 10% of benign tumors, but less than 5% of the malignant ones. The malignant tumors are usually stage 1. Pathogenesis, interesting question, is probably quite varied, and that may be not surprising given the fact that we have lots of other areas where mucinous epithelium arises, both in the urachus, in the bowel, in the lungs, salivary glands, and so forth, cervix, and so on. So surface epithelium maybe, germ cell origin maybe, other kinds of implants, endometriosis, all of these are still within consideration for some of these tumors. Even Brenner tumors, again, sometimes have mucinous epithelium. Fortunately, we don't have to define that. We just need to define their behavior and stage them appropriately so they get the best care. These can be quite dramatic tumors. As is often said, if it's big, it's mucinous. If it's really big, well, it's probably benign then. So these 10, 20 kilogram tumors may be just borderline tumors, or maybe just serous, or maybe just mucinous cystadenomas. Intraoperative evaluation with frozen section, fraught with problems. The sampling issue is the big one, and so forth. And so generously sampling mucinous tumors at the time of frozen section can be useful to help steer and guide treatment. I would say we typically do between 2 and 4 tissue sections of any given mucinous neoplasm, maybe even a few more if there are differing morphologies that need to be evaluated grossly. If you see a bilateral ovarian tumor, well, you should always be concerned about the possibility of extra ovarian origin. But I think even in any ovarian mucinous neoplasm, the surgeon needs to know what kind of mucin you're dealing with. And they need to be alerted to the fact that it's a mucinous tumor so they can do the due diligence to rule out extra ovarian origin. If we have an intestinal type tumors, those especially need to be generously sampled because those can frequently have both the benign, borderline, and malignant areas. Here's a sample gross picture. We can see multiple locules, variable glistening surfaces. You don't get a sense for the slippery nature of the mucin with a gross photograph like this, but as you open it, you can oftentimes get a feel for whether or not this is a high viscosity or a watery type of fluid. Here's another example where maybe we can see a little bit more of the glistening mucinous type of fluid, and we see variable cysts and some solid areas in between. Here's a mucinous carcinoma with clearly maybe more serous type of central core area, maybe some more fleshy areas, and variable size cysts. Here's a nice image of a benign mucinous adenofibroma showing a dense fibrous stroma and these clear mucinous type epithelium with the abundant pale eosinophilic or pale clear cytoplasm with basally oriented nuclei. Now, occasionally you'll get combined mucinous and serous lesions, and that's appropriate to report the combined epithelial elements that you see. Here's another example, a mucinous cystadenoma, delicate papillae. This does not merit the diagnosis of borderline, even though you have little papillary structures here. This is very filiform, widely spaced papillae, single layer of cells, and no secondary branching, as you note here. This would probably be an endocervical type of mucinous cystadenoma. What can be a challenge sometimes is the presence of sort of cyst rupture, incomplete glands. That's a criterion for malignancy in some organs, but not in the ovary. And so certainly it should raise your concern, but it is not the sine qua non for making a diagnosis of mucinous carcinoma. So let's move and talk about one of the specific subtypes, the mucinous borderline tumor of the intestinal type. These are lesions which generally will have some degree of cytologic atypia. Doesn't have to be greater than 10%. It can be less than that. And it doesn't have to have hierarchical branching. It may have other types of GI cells, pan-S cells, and so forth. But you certainly may find mitoses and varying degrees of atypia and stratification. If you find intraepithelial carcinoma or microinvasion, then you want to make sure that you've thoroughly sampled it to not miss a potential area of invasion. So here's an example. We can see here some goblet-type cells admixed with these other mucinous cells. You can see a slightly bluer hue to the goblet cells here that give you a clue that it's an intestinal or enteric type of mucinous neoplasm. This would fall into the borderline category because of the degree of epithelial complexity and proliferation here. Here's sort of a pseudo-cribriform pattern that can be seen. This may be due to tangential sectioning and variable. We can see the variable size orientation of the stromal cells is quite different. But we'll then see a few of these more filiform projections up above as well. Here's another image that we can see, and here you note the cytologic atypia. We have the filiform projections. We begin to see some nuclear enlargement, a little bit of hyperchromasia. Even though most of the nuclei are basally oriented, they begin to take on just a degree of more subtle atypia. Here's another example. Here we see numerous goblet cells in this lesion, looking very much like an intestinal crypt. Microinvasion can be seen, and here we see an example of that with this normal mucinous epithelium up above and stroma containing little nests of cohesive tumor cells that have invaded, and occasionally even some single cells here, for example. These tumors can recur elsewhere, involve other locations. This is one in the bowel. This shows the recurrent tumor with contrast this to, here's the tumor here in the bowel wall, and you can see it here out on the outer portions of the bowel wall with the normal colonic mucosa, or small bowel mucosa up above. Here's an example with high-grade dysplasia, high-grade atypia that would qualify as intraepithelial carcinoma. And we see these from time to time as the degree of atypia. In some areas, you can see very mild, more moderate, and potentially very severe, full-blown intraepithelial carcinoma. And that is one of the WHO categories that you would be able to then make that diagnosis when you find those sorts of areas. Here's another example, more cribriform type architecture, higher grade nuclear atypia, some rounding up of these nuclei, a little bit of upward migration and disarray to the nuclear orientation. Here's another example of the high-grade dysplasia here in the glandular functions with an invasive or microinvasive area of carcinoma extending into the stroma. Now, in speaking about invasion, there are two categories of invasion. We've been looking primarily at the destructive stromal invasion, or the smaller nested cell type of invasion. But there's another category which is referred to as the pushing border type of invasion, expansile invasion. And this is characterized by a very abrupt change from the clear-cut neoplasm and an eosinophilic stroma. Very often, and most often, these borderline tumors will have a more amphiphilic or a more ovarian type of pink-purple or bluish stroma that subtends them. And when you don't see that, you should very seriously begin to consider the expansile type of invasion, and thus qualify the lesion as a mucinous adenocarcinoma. So invasive mucinous tumors can have either of these patterns of invasion, infiltrative or expansile. Sometimes necrotic luminal debris is a marker for this type of process, but it's certainly much more frequently found in metastatic tumors that involve the ovary. So if you see a lot of dirty lumina, dark and dirty, as we say, then you should think, could this be a metastatic tumor? Likewise, signet ring morphology is not very common in primary ovarian mucinous tumors, and similarly for colloid carcinomas. So we can see, mucinous colloid carcinomas from the appendix, for example, or signet ring cell tumors from the stomach or pancreas, more frequently than we would recognize a primary ovarian tumor with that morphology. Immunohistochemistry, well, it has some role to play. Most primary ovarian tumors are CK7 positive and CK20 positive, but some show other patterns, and particularly those that come associated with a teratoma, where you may have a CK7 negative, CK20 positive tumor. The enteric versions not infrequently will express CDX2, and thus reliably differentiating them from primary versus metastatic is problematic. But certainly more frequently, metastatic tumors are almost uniformly going to be CDX2 positive. They'll usually be negative for the hormone markers, P16 may be positive, and so forth. So you don't get a lot of help here, but sometimes in the distinction between gastroenteric versus primary ovarian, you get a little bit of help with the immunohistochemistry. Here's some examples of the expansive invasion, the confluent growth of carcinoma. Gives you a clue that you're not just in borderline territory anymore. And these areas tend to lack any evidence of infiltrative desmoplasia or anything of that sort. Here's a very characteristic infiltrative pattern with some desmoplasia. So you do see this pattern as well. usually with a very high grade and pleomorphic, poorly differentiated mucinous tumors. Here's another area with infiltrative pattern growth, mucinous carcinoma. And you can see on some edges here, it's not very atypical. So the transition can be abrupt, and hence, again, the need for generous sampling. Here's a mucinous neoplasm associated with a teratoma. The dermoid cyst is not shown here, but we can see this incomplete gland here and not the typical stroma here that we would like to see. And in fact, here there were dissecting pools of mucin associated with this tumor, some of which had epithelial component, as we see there. Now, the other major type of mucinous tumors in the ovary are the endocervical type. These tend to be a little bit smaller, younger patients, usually low stage, and as indicated by the name, the tumors resemble endocervical columnar epithelium. They may have some ciliated cells and so forth. Invasion, not infrequent, and these can tend to be positive with hormone receptors and would obviously be negative for your enteric markers. I've never used mesothelium on these, but it's reported to also be positive as well. Here's an example of one of these, maybe not as multicystic, a little bit more soft and fleshy, pale lining tissue. And here's a microscopic image. So we can see here's endocervical type borderline tumor. We see the papillary tufting. We see a higher degree of nuclear atypia than you'd like to see in a benign tumor, but we don't see invasion in these fields. Here again, higher magnification, showing the degree of atypia that you can see in these tumors as well. A little bit different, subtly different atypia than seen in the intestinal type. And here's the glandular pattern at low magnification, showing you this abundant pale cytoplasm, the stroma, and note that here the cells mark with estrogen receptor quite nicely. A rare occurrence in these mucinous neoplasms is the presence of sarcomatous type growth as a nodule within the wall. Of course, anytime you have a nodule in a cystic tumor, you want to sample that generously, whether it's a teratoma or whether it is a mucinous tumor. Here's what we see with this one. We see some borderline intestinal type epithelium up here, and then here we see this mural nodule with a very solid sarcomatous type tumor with pleomorphic and giant cells, and just a wild degree of atypia. So that brings us to the end of the trail, or maybe it's the beginning of the trail for you. I do appreciate you joining with me and enduring through this somewhat challenging area of ovarian pathology. We'll try to come back with the other main common epithelial tumors at a future time. And as always, please subscribe, share your thoughts below, and so that we welcome your feedback. Please don't hesitate to connect with us on Facebook or here on YouTube or otherwise.